hey, just remember it's another one down. We're still moving forward, so that's good stuff. All right. We're almost done. We're almost done. So the stuff that we talked about yesterday, remember we talked about the overall country risk, there's your high, very high. And here's a couple of other categories that you would use as a planner so that you could do some preventive measures against. This is everything that we've generally talked about, right? Foodborne stuff, vector-borne stuff, sexually transmitted stuff, so education, using protection, prophylaxis, you know, anything that you can do to kind of prevent these issues is what we do. The big thing with this slide is to remember that NCMI calculates it without any preventive measures or countermeasures. Remember, it is the worst case scenario. And so that risk that you have there is the worst case scenario risk, period. Then it's up to you as a planner to add preventive measures or countermeasures so that you can get the residual risk. Okay? That residual risk is going to be based on what you can come up with to decrease that worst case scenario. Okay, whether that be bringing in bottled water, whether that be handing out chemoprophylaxis before folks go, whether it be educating people, whether it be making sure all their vaccinations are up to date, all of that could be considered countermeasures or preventive measures. Now, the main reason, right, don't forget that main reason why NCMI does it that way is to ensure that everyone is on the same level playing field. Okay? Everyone has that same worst case scenario standards. So when you get it, you're going to tailor it to wherever you're going, or wherever it is that you're going to be is what you're going to use to hopefully decrease that worst case scenario. That's all that is. And here it's telling you your residual risk refers to the remaining risk, right? Whatever's left after you've added your preventive measures or your countermeasures is your residual risk. That's what you're going to deal with. The big piece to remember off of this slide is that we evaluate risk with countermeasures in place. Okay? It's a big thing to remember off of this slide. Right? So you can have a plan, and you can have all these things set in motion so that you can prevent as much stuff as you can until you get to wherever you're going. And then you get punched in the face, and then your plan's out the window, right? So when you get there and you notice trends, you notice that people are still getting sick for other reasons, you need to reevaluate, and you need to add either countermeasures or preventive measures to ensure that that stuff doesn't continue to go on. Okay? That's the big thing with this slide. Now remember there at the bottom, the medical threat rates are some of the things that you are going to be doing for your soldiers. Okay, current travel, remember, you are both a deployment doc and you're a travel doc. People are going to go on vacation. You just need to figure out whether they're going on vacation or whether they're going on a deployment. So you got to make sure that you talk to them, figure out what they're doing, and then you can come up with a plan to protect the traveler. And you want to keep them from getting sick or possibly dying to doing some kind of crazy stuff. All right. Okay, here, risk is going to be difficult to estimate. Right? It's really dependent on what they're doing and why they're going to wherever it is that they're going. Right? But the big piece to understand here is that you can mitigate the risk, but you're not going to eliminate all of the risk. Right? You can add countermeasures, you can have preventive measures, but you may not be able to eliminate all that risk. So there is still some inherent risk that's going to possibly happen. Just because you give somebody vaccines doesn't mean that that person's not going to get that sick. Remember, vaccines aren't 100%. Okay? You're not aware of that? Vaccines are not 100%. Okay? Some are pretty close. They're not. Okay? Chemoprophylaxis is not 100%. So there's still inherent risk there. Right? These are all the things that we're going to do for them. We're going to try to help them get so that they don't get sick when they go away. talk to these guys, there's certain things that you really need to get. The itinerary is pretty important, right? Where are they going? What are they going to do? Right? Is this going to be an operational thing, or is this going to be a pleasure thing? Like vacation. Medical history is extremely important. One of the biggest things that people usually forget from a travel doc perspective is the medications that they use. Okay? Both for deployment and for vacation. Right? So if they're coming to see you and they're going to go away, I usually give them a month more medication than they actually need when they go away. Why? Because they may get stuck. Right? If they get stuck, they're going to need more medication. And that works on both ways. That works for deployment's sake, and that works for vacation traveler's sake. So keep that in mind when you are talking to these patients about going someplace. Okay, immunizations. Either go to the CDC website, or you could go to Necros, ASIMS, MERS, and go to that specific AOR, and it'll tell you the shots that you're going to need for that place. Later on, there'll be some links to take you to that CDC site for travel docs. And you can put in the country, and the country will pop right up, and it'll tell you everything you need to know through the CDC site. If it's a malaria area, educate them, give them prophylaxis, tell them they need to come back and see you for post-prophylaxis. Okay? Self-treatment medications. We're going to get into some of these things, but sometimes when you go on vacation, like you get hurt, you get a rash, right? You got to go to some store someplace that's super, super expensive, or there's stuff in there that you've never seen before, so you don't know what to get. One of the things that I usually tell my patients are, look, make yourself a little kit. Right? So histamines, pain relievers, Benadryls, cream. Right? So this way you'll have a little something if you really need it when you're in the middle of nowhere, or in a foreign country where you can't go to the store or don't understand what's in the store. And ultimately that personal hygiene there, or that personal preventive measure would be that hygiene stuff. And make sure you wash your hands. Be careful on what you're eating, okay? The safe food practices. And then make sure you wear sunscreen, and make sure you protect yourself against bugs. Don't tell me you eat. All other good stuff, right? So here, for your itinerary, right? Where are you going? When are you going? Why are you going? Okay? You try to figure all this stuff out, because that's all going to kind of help you build a picture so that you can give them the best plan that you can possibly do, right? The big thing here is to determine whether it's a vacation or it's operation. Current medical conditions. Important two different ways. One, if you're going on vacation, you need to make sure that that person has enough medication to take care of them while they're gone, and I usually give them more in case they get stuck. Right? That's one. But if this is operational, for those of you who have been deployed to CENTCOM AOR, there is what we call mod, used to be 13 and 15, I think now we're up to mod 17. That tells you the requirements for people that are able to go into that specific AOR. So depending upon what kind of medical conditions these people have, they may not be allowed to go into that AOR. And if they haven't, in many cases, you have to submit a waiver to the surgeon there for them to review whether they'll say yay or nay to allow this soldier into that AOR, if it is operational. So these things are kind of important. Past medical history, if they got some psychiatric issues and this is an operational issue, then they're probably not going to go to the CENTCOM AOR. They usually don't necessarily grant waivers for those folks. And then obviously the medications are on any kind of allergies, or vaccination history, you can give them more vaccines to keep them up to date, depending upon where they're going. Okay. Immunizations. Yeah, the ones on the left, those are more travel stuff, depending upon where you're going to go travel to. versus the routine stuff that's on the right that you're gonna get from being a little kid on up. Just remember that every AOR has a specific set of vaccines that are required to be in that AOR. Going to an area that is malaria endemic, please give them some chemoprophylaxis. Please explain to them what malaria is, and then please tell them that they need to come back and see you for post-prophylaxis, and why they need to come back and see you post-prophylaxis. All right. The other important thing for you to understand as to where they're going is you can figure out whether it is quinine or not quinine resistant. If they do come back and they do start failure, if they do start coming up with their little cyclic fevers, positive, smear, then you will know whether you can or cannot give chloroquine type medications to make it better. Self-treatment medications, hey, tell them to make sure they take some Tylenol, Pepto, Band-Aids, A-straps, little plastic baggies. They can make their own little aid kit, put it in their bag just in case they need it. That's usually pretty helpful for vacation travelers. Right? Thyroid diarrhea, you guys remember this stuff? Right? The most common is usually E. coli. Right? One of the most common illnesses expressed by travelers when they go someplace, usually because they're eating something that they're not used to eating. It tells you usually resolves without treatment in 4 to 5 days. That's usually uncomplicated for the most part. But then you can still have invasive traveler's diarrhea, which is now complicated. Those guys, usually don't give them antibiotics. The standard traveler's diarrhea, which usually gets better within 4 to 5 days, self-limiting, no antibiotics required. Here it tells you that 80 to 90% traveler's diarrhea is bacteria. Knowing that 80 to 90% is bacterial, would you give them something to stop them up?
No.
Correct. Answer should be no. All right. We want the bacteria to come out. Okay. If we give them something and it starts backing them up, that bacteria is going to get backed up in the gut and it's going to get worse. That's usually why, at the minimum, we wait 48 to 72 hours before we decide to give them any kind of medication to stop them up, like loperamide. Right? The other differentiator that you should think about when we're thinking complicated versus uncomplicated traveler's diarrhea is, do they have a fever? Okay? If they have a fever, then it's probably invasive, which means you most definitely don't want to back them up at least for the first 72 hours. Let them blow that stuff out. That's good for them. Okay? Just gotta make sure they keep them hydrated. Those folks, you will probably have to give some antibiotics. But if it's uncomplicated, it's getting better, no fevers, and then you don't need to give anybody antibiotics. All right? And even if you look at the norovirus and rotavirus, that's 5 to 8%. Those are all self-limiting, right? So no antibiotics either. So here, self-treatment for traveler's diarrhea. So part of making a little kit is explaining to them what kind of stuff they should probably go to the store and buy to make their little kit with, right? So here it's telling you mild diarrhea, loperamide, and bismuth, subsalicylate. All right. Can you buy loperamide over the counter? Yes. What's it called? Imodium. Right? So even if you don't prescribe it to them, they can get it, right? Now, the question really is, do they understand how to use it? That's where you come into play. It's like, hey, if you're going to use some Imodium, hey, don't use it if you have diarrhea, or if you have bloody diarrhea, or if you have fever with diarrhea, right? So at that point, you can explain to them, hey, it might be bacterial, which means you need to let it come out. What's bismuth subsalicylate? Pepto, right? hey, they can take the little Pepto capsules, not necessarily the liquid, right, because you can't carry liquids, and they can put the little pills in there for the kid. So you can kind of sort of help them along picking certain things that may help them to make their little kid. So here for moderate to severe diarrheal peritonitis with or without antibiotics, based on fever, for the most part, based on fever, because you're not going to be there doing a stool set. And then here you've got the antibiotic options. The most common one that we're starting to use now, more so than Cipro, is the azithromycin, because Cipro, we're starting to find some resistance to fluoroquinolones. We're starting to use azithromycin a little bit more. We're already using azithromycin more so in Southeast Asia because of the high resistance rate to fluoroquinolones. So even in other places now, we're starting to use azithromycin a little bit more than the Cipro itself. That Amcolo, I really haven't seen anybody really prescribed it. That is a very specific medication for traveler's diarrhea. It's really what you generally use it for. The only deal with that medication is that it doesn't generally work on any other bacteria other than E. coli. Right? So if it's not E. coli based, then it may not really work too well for traveler's diarrhea. Okay. Chemoprophylaxis, I need you to know this. Not recommended for traveler's diarrhea. Right? You do not give people chemoprophylaxis for traveler's diarrhea. Alright? You can help them make the little packet, and you can explain to them when and why to use it, but you shouldn't necessarily give them prophylaxis. And when I say prophylaxis, I mean give them some azithromycin or give them some Cipro, right? Give them some rifamycin. Here, take this stuff. Okay, if you have diarrhea, take it. Not necessarily the case. That's generally how we start building resistance, especially if they don't need it for that reason. Okay? So, no chemoprophylaxis. Alright. Alright, altitude sickness. Three big things that we really concern ourselves with is acute mountain sickness, HAPE, high altitude pulmonary edema, and PACE, high altitude cerebral edema. Okay? HAPE and PACE are potentially fatal problems. They are potentially fatal problems. If we remember, at sea level, the atmospheric pressure is approximately 760 millimeters of mercury. That's the standard. And the oxygen is made up of approximately 21%. Okay? That's sea level. Okay? At 10,000 feet, things change, right? Air gets thinner. Okay? But PO2 is about 70% of what it is at sea level. So you have a decreased amount of pressure that's allowing oxygen to be available to the lungs at that point. Okay. So you're ending up with hypoxemia once you start going to elevation. Now, on average, they say about 8,000 feet is usually when acute mountain sickness starts. All right. I'm going to start with acute mountain sickness because that's probably the lowest you'll be before anything starts happening. Right. So you have slightly bit less oxygenation as you continue to go up, right? So you, on average, will say about 8,000 feet. So you'll be about 8,000 feet. You're not going to be getting as much oxygen as you're used to. This is the mildest and most common form of altitude sickness, is acute mountain sickness. Right, so generally around 8,000 feet. Dizzy, lightheaded, and nauseous. Right? What do we generally do for you? Usually you stop, right? Stop ascending. You use acetamide You can give some folks some fluids, you can give them some NSAIDs for headaches. That's pretty much it. If you remember anything from altitude sickness, remember that when people get sick, you need to descend. Descend is the key. Okay? A lot of times folks are like, well, just give them some acetazolamide. Okay, that only works for acute mountain sickness, and you can try a little bit for haze, but not necessarily the appropriate medication for haze. Okay. So, do you guys remember the pharmaceutical stuff? Did you guys do acetazolamide? Okay. So what does it do?
Anhydrase. Yeah.
It does what?
It's diuretic.
It's diuretic. It's probably correct. Anhydrase. So what it does is it helps your kidney decrease bicarb, increases acidity in your blood, which causes you to breathe faster. Right? And as you breathe faster, you somewhat hyperventilate, but as you're hyperventilating, you're increasing your oxygenation. That's all it does. Doesn't do anything else. Right? So that is the one medicine that you would generally give for acute mountain sickness. Aside descending or stopping your ascent, depending on how bad the symptoms are. Okay. Now, you have haze. Okay, we'll go straight into haze. And the reason why I go straight into haze after talking about acute mountain sickness is, if you do not take care of acute mountain sickness can lead to haze, high altitude cerebral edema. Okay? And that's just what it sounds like. Okay? Your brain is right up inside your skull, and your skull ain't moving, so your brain gets squashed. That's what's happening. Okay? That person's going to end up having some hallucinations, and you pass out, you can have a coma, you get dizzy. It's going to have a whole bunch of stuff. Okay? Because his brain is getting squashed. Right? But that could be a complication of acute mountain sickness if you did not take care of it. Right? Haze is a potentially fatal problem. Usually happens when you go greater than 11,500 feet. So you gotta be up there. Right? You gotta be up there pretty high. And haze is one of those late stages of acute mountain sickness. Right? So, what are you gonna do? It's a medical emergency. That's what this is. Haze is a medical emergency. What are you gonna do? What did I tell you you're supposed to do? Descend, exactly. That is the very first thing you really need to do with this guy. You need to stick him on a stretcher because he ain't walking, and you need to descend as fast as you can, right? And what else are you going to do? You have oxygen, give him some oxygen, right? By all means. So what's the mainstay medication that I'm going to have to give this guy?
Steroids.
Steroids. I'll probably give him some dexamethasone, right? Because everything's all swollen up, and I need to knock down that swelling, right? So dexamethasone is probably the best medication that you can give this guy. You can try some acetazolamide as well. That'll cause him to hyperventilate and try to get more oxygen into his system, especially if you give him an oxygen mask. It may help some as well. But just remember that most folks think that just giving acetazolamide to everybody with acute altitude sickness is going to help, and it's not the case. All right. So that's what you do with haze. Now, the question is, what do you do with hate? Hate usually starts about 8,200 to 9,800 feet in elevation. Right? And all that is, just like it sounds, right? High altitude pulmonary edema. Right? Pulmonary edema. What does that mean? Fluid in your lungs, right? Fluid in your lungs. Why do you get fluid in your lungs? Well, now you don't have enough pressure to get oxygen into your vascular system anymore, which means now your vascular system is getting squashed, and and that extra pressure in the vascular system is causing it to leak. So now you're getting that extravascular fluid leaking into your lungs. That's your pulmonary edema. So this is happening inside your lungs. You're becoming hypoxic as well, right? So what do you do to treat it? Descend, right? You go down. We're not here to trick you. Right? I'm trying to get you to understand, whenever you have high altitude illnesses, bring them down. If you don't have any meds, bring them down. Okay? They'll actually start getting better as you bring them down. It's going to take them a little bit, but they'll start getting better even if you don't give them any meds. Right? So now, we understand that we're going to bring them down. We're going to give him oxygen, right? We're going to give oxygen because he's hypoxic. Now, what kind of medication do you think we can give him that may help his lung situation?
Nifedipine?
Say again? Yeah, we're going to give him some oxygen. Correct. We're going to give him some nifedipine. You guys remember that from pharmacology? What is nifedipine? What class is it? Calcium channel blocker, right? And what is the main mechanism of action of nifedipine?
Lowers blood pressure.
Decreases pulmonary arterial pressure. Decreases pulmonary arterial pressure. That is why we give it to him for taper. Okay? It's going to decrease the pressure that all the vessels are going on inside the lungs, so it stops bleeding inside the lungs. Okay? So that's why we give him nifedipine. But we're also going to descend him. So he's going to start hopefully getting better as you descend, right? So, good stuff. All right. I need you to know this slide, and I need you to know that box is blocked. Okay? So, past history of altitude sickness is your first line. So if somebody comes to you and tells you, yes, I've had altitude sickness before, okay? If they're going anywhere between 8,000 and 9,000 feet, you can consider prophylaxis. But if they are going greater than 9,000 feet, we need to recommend prophylaxis. That means they need to take it. Okay? Because otherwise they're going to get sick. Versus the next line where it says no history of acute or no history of altitude sickness, where you can consider 9,000 to 11,500 some prophylaxis. By being greater than 11.5 for recommendation. Right? That'll be you getting that HPI. If you don't get the HPI correct, it's going to be hard for you to decide what you're going to give them. But if you didn't do that itinerary and ask them where you're going, what you're going to do, are you going to be at altitude? Do you have a past medical history of altitude sickness? Right? It might be hard to say that I'm going to give them some prophylaxis. The prophylaxis that we're talking about is the acetazolamide, okay? That hopefully should keep him from getting sick. At which point you explain to him, hey, these are the signs and symptoms, or some signs and symptoms on that last slide that you talked about. If you do, you need to stop and rest. If not, then you need to descend. Okay? But look at the elevations and look at the ones with past history of altitude sickness versus no history of altitude sickness. All right? And that acetazolamide is that carbonic anhydrase inhibitor that's going to make them hyperventilate. All right? Jet lag. I don't know if you guys have gone through this. All right? Across the time zones. All right? When you're on a plane for such a long period of time, your circadian rhythm gets knocked out of whack, right? You got to figure out how do I get back onto my cycle. There's quite a few different ways, and here it's talking about poor sleep and early awakening, which is part of the problems, right? And there at the bottom are some of the strategies for prevention and treatment, so you can adjust your sleep time. Pre-travel before you take off, so that you're already set on where you're going, time, circadian rhythm. That one doesn't usually work. Usually the bright light usually works. That one usually keeps you awake. Don't take naps. Now, I will tell you the two big ones that you see there on the bottom, the medications, Ambien and Restoril. Those are generally the ones that we'll carry with us, that we can give our folks. We're going to give it to them on the plane, so that by the time they get to wherever they're going, they're rested. But we have to time it appropriately, because if they're showing up someplace and it's daytime, we're good. But if we're showing up someplace and it's nighttime, and they're rested, they're not just going to sleep that day, right? So you gotta make sure you time it appropriately. Now, Restoril, I don't like. It is a benzodiazepine used to treat insomnia. Psychiatrists prefer Restoril. I do not. I have actually tried Restoril, which is the main reason why I don't like it. Right? So, one of the side effects of Restoril, because you need to remember the side effects of some medications you're prescribing, right? Some of the side effects of this one is feeling like you're awake, but you're actually asleep and you can't move. That's a horrible feeling. I still remember it. Right? So that is a side effect of Restoril. So you have to keep that in mind. Remember, both of these are addictive. And the longer you use them, the more you're going to require. Okay? Not just frequency, but in dosing. So we only use these for a very short period of time. If we're using them for jet lag stuff, usually we give one pill to everybody on the plane. Say, hey, if you really want to go to sleep, then you can take this, and you'll be on the plane soon. Right? So hopefully by the time you wake up, they'll be ready. So keep that in mind. The other one that we have is that Ambien. That's a non-benzodiazepine sedative hypnotic. You guys remember that from pharmacy. Now, problem with Ambien, though I like Ambien more, is it will help you fall asleep, but it doesn't keep you asleep. Restoril helps you fall asleep and keeps you asleep. Ambien only helps you fall asleep. But Ambien has what we call retroactive amnesia. So there's a small portion of the population that you give it to them, and they will go to sleep, but they will get up, go do stuff, and then go back to bed. And the next morning when they wake up, they don't remember that they did anything. That is a side effect of Ambien. Okay? Retroactive amnesia. Again, keep these things in mind when you're starting to prescribe these things. Okay? So here's some other things that you can talk to your patient about, especially if they have motion sickness. They can get some antihistamines. I like to prescribe the scopolamine patch, right? Because then they can take the patch and they just put it right behind the ear and leave it there and they'll be okay. Pretty good to send folks on cruises with if they think they're going to get seasick. If people have recurring bacterial or fungal infections, you can give them some stuff. You can give them some Bactrim or some Cetera to take with them if we know that that's a problem that we generally have, right? Or depending upon where they're going to go, and there's nothing going to be around, you can give to them preemptively. And then the common stuff like Motrin, decongestants, Zyrtec for allergies, Linux, throat lozenges. You got to put it all in a little bag or something. They'll have it ready for themselves. Here's some personal protective measures. Here's a whole bunch of different ones. You don't have to necessarily talk to them about every single one. You can pick some of the ones that you want to highlight, depending upon where they're going or what they're going to do, just to ensure that they don't get sick. Just mention these so that they understand what's going on. Right? So when you're talking to folks, explain to it, it's not boiled, peel it, cook it, forget it. It doesn't matter, because you don't know where some of these things have been grown, you don't know what they use to grow them. There are some things that don't get killed with boiling, like Giardia doesn't get killed when you boil water. Okay? So you just gotta make sure that you educate. Hey, be careful with street foods, be careful with eating any raw foods. Right? Be careful if they're washing the food with the local water, because you don't know where that water's coming from. Right? Just simple things like that. If they are in the military, by all means, tell them to make sure they wear their uniform appropriately. Give them some DEET, tell them, hey, make sure you wear the DEET on any exposed skin. You get a bed net, the military issues it to you, use it if you're going to a mosquito-ridden area, especially if it's that time of the year, wherever they're going, for mosquitoes to be out. I've been to resorts that actually have mosquito netting all over the bed, just because there's mosquitoes in those areas. At least that'll protect you. Okay. What's the most important thing after you get bit by an ant? It's the very first line there, right? Immediately wash the wound with soap and water. Okay? That is the most effective thing that you can do initially, and then they come see you, right? Okay. So if I have gotten the vaccine, would you give me immunoglobulin? The answer should be no. Half of you are not giving me the left-right. Okay. That's not good. Okay. I think this is going to be one of the questions on the test. All right. So remember, if someone has the rabies vaccine, you do not need to give them immunoglobulin. Right? If they do not have the rabies vaccine, they're going to get the rabies vaccine and they're going to get immunoglobulin. Okay? Keep that in mind. But the very first thing you're going to do is wash out that wound. Alright? Screening folks post-travel. Right? You can talk to them and let them know, hey, when you do, how'd everything go? If they were in a malaria area, give them some post-malaria medications, tell them how long they need to take for. Right? If they started having intercourse overseas and you're not quite sure what kind, you may want to do some STD testing. Don't know what happened if you go to an area that's endemic for tuberculosis. You want to get checked for TB. Right? So these are all things that you can talk to them about when they come back and see you after their vacation, or if they went on a mission after a mission. Have any of you heard of the Health Surveillance Explorer? No? So this one's a more open source. Instead of like NCMI has its own little secret one, this was more open source. It uses like everything you could possibly find. And it's run by DHA. Okay. And it allows us to take open source information about health events anywhere, and it helps inform the DoD, us, higher, right? Any kind of health encounters that are happening around the world within any of the AORs. It looks at global emerging infection surveillance in different parts of the world, which help us be able to plan better. That's where we're going to take us. That's where they're going to send us. All right. That little link at the bottom will take you there. You just need CAC access, and it'll let you on. It's actually a pretty cool site. So let me see if this thing is going to work. Okay. So hang tight for a second. Sound. Right now, I'll make this thing sound come on. Yeah. So this is kind of it's actually going through what it does and what it looks like. And you can see it's giving you like all these real-time information pieces, so that you can look at those areas and you can start making decisions. You can figure out what kind of countermeasures you can do. You can figure out what kind of protective measures you can do within that AOR that you're going to go to. You can put in specific diseases, and it'll pull up information for those diseases in the areas that you're looking at. Right? So it's pretty nice. It's actually run by DHA. It's probably one of the only things that we could probably say DHA is actually doing well. The other nice thing is that it actually pulls up all the regulations too if you read them when you're going through it. See all those dots everywhere? Lots of information in this thing. Lots. Yeah, sorry, doesn't have the sound. It's actually a pretty good site. Alright. And this link down here will take you to the site, and it's tech enabled, so you actually have access to Zoom, just let you write on it. So pretty good site. Here's some more links to other sites. Okay, that yellow book for the CDC, that's actually the site where you can go and put in wherever country the person's going to go to, and then put up all that information for you. All right. There's a couple of other places. There's NCMI right there for you. DHA Novax. Here I'll talk about all the vaccines and stuff like that. Give you information. This is what that Travelers Health CDC website looks like. And if you look on the right side, it says for clinicians. Bam, you just put in your country here, and it'll take you all information for that country. Okay, that you can talk to your patient about. Yeah, Travex here. This typically refers to like travel medicine services or clinics around the country. That'll help you find them. It's also an online database for preventive and travel health information. And we've got this one, it's also run by DHA. And it just goes through all the different AORs. Anybody have any questions? No? Yes, maybe? All right, so I think from here, so either from slide 47 or 48, they're just slides for your general purpose information. Okay? You don't have to worry about looking at those. Got it? Questions? All right. Disease after a disaster. The World Health Organization disaster book is hung on Canvas. You guys want to download that and keep that. If they ever get to send you off to a disaster, you'll have it so that you have something to reference back. Back in 2012, if you guys don't remember, there was that Haitian earthquake, that was 7.0, that destroyed almost all of Port-au-Prince. I got 150 bodies set, prepped, deployable on an airplane in less than 24 hours with me sitting on the airplane, and I get yanked off the airplane because they said, no doc, you can't go. There's too many providers on ground already, and there's not enough security to take them out to take care of folks. So I didn't go, but I was able to get 150 people in less than 24 hours prepped to go help humanitarian mission. Okay? And that may be something that you guys will have to do. So keep that in mind. There's learning objective. There's some enabling learning objectives. So consequences of disaster, right? It's bad. It causes serious health problems, it causes social problems, it causes economic problems. Right? I just told you 2012, Port-au-Prince, which is the capital of Haiti, was completely demolished. Okay? What kind of effects do you think that had? There were lots of human consequences that go along with it. Right? There was a lot of dead people there because of that. Right? There's a lot of injuries. There's a lot of disabilities. There's going to be lack of food. There's going to be lack of safe water. There's not going to be sanitation. What does that mean? That means that disease is going to start causing outbreaks. Right? There's going to be malnutrition problems. So there's a lot of things that come about when we have natural disasters. Okay? Oh, and developing countries are disproportionately affected. So if you're not aware, Haiti is probably the poorest country in the Western Hemisphere. Okay? So the entire world actually went to go help during that time period and donated a whole bunch of money to try to help rebuild that country. Right? So remember, underdeveloped countries usually have it before because they don't already have that infrastructure built, and whatever small bits of infrastructure they do have get destroyed, then they have nothing. So keep that in mind. Right? So deaths for natural disasters are usually in high numbers. Okay? They're usually caused by blunt trauma, they're usually caused by crush injuries or drownings, especially if it's a water-related natural disaster. All right? So here's the thing. The sudden presence of large numbers of dead bodies, okay, in a disaster-affected area usually scares people. And I don't blame them, right? If I see a whole bunch of dead bodies, I'd probably be somewhat concerned too, right? The problem with that is that it causes fear in folks, and people start thinking that there's gonna be outbreaks of things. Now, with all the studies that they've done, there's no evidence that dead bodies pose a risk to start or cause epidemics. Following natural disasters with some caveats, right? So what kind of viral hemorrhage diseases that we talk about that can still cause these problems, that can still cause epidemics? What is it? Right. Remember, I'm fat, old, and I can't pee and I can't climb a tree. So you gotta be clear. What are some of the viral diseases that we're talking about? Ebola would be one, right? Because remember, those bodily fluids that that person still has is still contagious after that person's dead. Usually, Ebola dies after a couple of hours after the person's dead. But if you're going to handle that dead person initially, you can get it. What happens generally when people die? They usually poop themselves. Right? Okay. Not all the time. But when you have stuff like this, pooping yourself happens. Okay? Sometimes we spread stuff via poop, right? So if people are handling these bodies, they can still get infected with something. Right? That's your little caveat. Right? If it is, or they've had some sort of infectious disease that could be spread by bodily fluids or stool, then there's a possibility that they could spread it when they're handling all the dead bodies and trying to put them somewhere. Right. So that is your caveat. Right? Here it's telling you human remains do not pose communicable disease hazards. Exceptions, viral hemorrhages. Right? Here it says louse too. Right? Because remember, if you're touching the bodies, they can like jump on you, they can climb on you. That's where that overcrowding thing and touching each other, spread to each other. Okay? And there it says avoid unmarked piece of graves. Right? It's not the Black Plague days. You don't need to like shove them all into one hole and cover them up. Okay? Part of what we need to remember is where we are in the world when this stuff happens. Okay? There's some folks that have culturally sensitive means of interment, burial, okay? How they handle their dead, how they say goodbye. So we have to be careful, and we don't want to just start putting everyone underground. And one of the things that we want to try to do is, reconnect some of those families and give them closure if we possibly can. All right? With an understanding that if they did have something infectious and we're handling it, we have to be very careful when we do that. Rapid detection. Cases of epidemic-prone disease is essential to ensure surveillance control. Now, what does this mean? Okay, in the next slide, there's a bunch of steps. I need you to understand whenever there's a natural disaster, people are going to huddle in certain places. Okay? That means that you're going to get a bunch of overcrowding. You're gonna get a bunch of unsanitary, it's gonna be an unsanitary location. Because nobody's gonna say, hey, the only place you can peer proof is over there. No. People are gonna do whatever they're gonna do when they're mass huddled, afraid, and have no idea what's gonna go. So you have to keep in mind that when that's happening, epidemics and outbreaks can occur. Now, the question really becomes, what do we do? Right? So here they gave us 6 different disease surveillance and early warning things to do, right, when you were there. Okay, you're going to identify the priority diseases and syndromes. Okay. World Health Organization has a guideline for some of this stuff, so you can just look it up in the book. If not, you can see what's most common there. You can see, depending upon when you arrive, what's actually happening, what kind of trends are occurring, so that you can kind of focus on the trends and knock them down. Right? That's one. You can set up a simple rapid reporting system. Okay? Figure out what the common symptomatology is of the problem, so that when people see it, they can report it. Right? And with that being said, you can train your healthcare workers with that same information. So as they're going out and taking care of folks, if they see it, they can address it, report it, and you can take care of it so it doesn't spread to other folks. Right? Designated lead agency. This is where it gets a little funny, right? Whenever you go to some other country, right, the question really becomes, who's in charge? Who is going to be the one doing all the controlling of all the pieces? Okay? World Health Organization a lot of times takes charge. There's other NGOs out there that sometimes when they go in, they'll take charge. What we like to try to do in many other countries, the equivalent of our CDC is the Ministry of Health. Okay, that's what MOH stands for there. We like to try to have their MOH be in charge because it gives them a face of the country, right? So that they can take care of their own folks and we can assist in that. How do we activate? How do we respond? How do they respond? Who are they supposed to see? Who are they supposed to talk to? Right? You gotta let them know. You gotta set something up so that they can reach specific people to let them know that this stuff is actually happening. And then the last one would be the monitor and evaluate the system. Okay? Make sure that it's still working. Make sure that people are still trained appropriately. Make sure that you're capturing these things before they actually become epidemics and lead to outbreaks. So let's go ahead and take a break. Triangle. Yeah. Make sure you remember all the 3 corners. Okay? Make sure you remember all the 3 corners. Right? In this case, we're just basically pointing out safe water, functioning latrines, nutritional aspects of being able to decrease some of these outbreaks. Okay? 4 serious infections that cause some mortality during some disasters, in this case humanitarian emergencies, are these 4 right here, right? And we've talked about these 4. We've talked about diarrhea, we've talked about respiratory issues and measles, but this is generally what we see commonly when we talk about humanitarian emergencies. Right? The other thing that's on here is malnutrition. Okay? And malnutrition is a major issue during humanitarian issues, often because it ends up becoming a life-threatening crisis or a life-threatening problem. More so for children under 5. Because they're just not eating right. Usually affects women that are pregnant or lactating and breastfeeding. Okay? And the elderly. Those are usually the more common population that has problems with malnutrition stuff. Contributes directly to mortality. That's easy to understand, right? You don't eat, you're weak. You don't eat, your immune system goes down. Especially for the folks that are more prone to a problem like children, right? Like the elderly. There's a statistic that it said malnutrition children are up to 9 times more likely to die during these natural disasters. That's for a bunch of different reasons. At that point, right, we have food insecurity. The babies aren't being fed appropriately because there's no food. Infectious diseases may start popping up. Right? So, things to keep in mind. One of the bigger ones are the vitamin deficiencies that start popping up in some of these little kids because of the lack of food. Okay. So here, the first one we're going to talk about is diarrhea. Here, diarrhea can account for over 50% of the mortality in the early phase of complex maritime emergency. Remember, these guys are probably going to end up in camps. Right? They're going to huddle together, right? The masses are going to be huddled together. So, if we talk about cholera spreads easily, right? Cholera can be a life-threatening problem. It's a bacterial infection caused by viral cholera. You guys remember that from ID? Spread by contaminated food and water. You're in a disaster scenario. The food and the water are going to be contaminated. So this is a possibility of what can occur. Severe watery diarrhea with cholera. Do I need to give any antibiotics for this? What's the best thing to do for cholera? Hydration, right? So when we talk about hydration, when we talk about emergencies and disasters, really we talk about oral rehydration salts. Okay? And the best thing to do for all these folks is get them a liter of good water, dump the oral rehydration salt in there, mix it up, and then have to drink it. Not only are you getting them clean water, but you're also giving the electrolytes that need to replace that they're losing while they're pooping. Right? Because as they continue to poop, they're losing more and more electrolytes, right? Which is going to make things worse for them. And here you got dysentery as well, easy of transmission. Okay? Only difference between dysentery is that dysentery will have that bloody stuff, right? Bloody watery diarrhea. And it's spread by fecal oral route. So when they're huddled in masses and don't have clean water, it's going to spread a little bit easier. So education becomes a big piece on this one. Make sure you wash your hands. Make sure you're doing all this stuff in one place, not all over the place. Right? And try to get them clean water if at all possible. Okay? Some of the other things that we might see there are E. coli, typhoid, hepatitis. Clinical presentations vary. You may have some asymptomatic folks, you may have some mild infections, or you may be severe respiratory diarrhea. Just remember that this thing is life-threatening. When you try to figure out what actually caused the problem, usually is bad water or bad food. So there's two main serotypes that cause viral cholera in humans around the globe. We have O1 that's most common globally, and then we have O139, which is most parts of Asia. So those are the two most commons that we have that cause this problem. Now there's over, you guys remember, there's over 200 serotypes of this stuff. So there's a whole bunch of different ones. Now remember, if you do get it, it'll only protect you against the serotype that you got. But it's not necessarily lifelong. Right? Not necessarily lifelong. It'll protect you for a little while, but eventually it wanes away. Okay? So you can always get it again. Okay? Other host factors associated with increased risk. Right? Genetic variations. We talked about them when we talked about IV. Here, if you're vitamin A deficient, that makes you more predisposed. And then, I know we mentioned hypochlorhydria once when we were talking about IV, but you guys remember you have acid in your gut, right? You have acid in your stomach. So as you eat stuff, a lot of times that acid in your stomach usually kills, right? Some viruses, kill some bacteria, kill some parasites. There are some people that have low levels of acid in their stomach. For those people, they become more prone to GI issues because they lack that acidic level in their gut. So more things actually make it to their intestinal tract. Other things to remember: natural infection, right, versus vaccine. Where we already know if you get vaccinated for cholera, every 2 to 5 years you need a booster. If you get natural immunity, we don't know how long that stuff lasts for. It'll eventually wane off, but we just don't know how long that is. And with vaccines, we know it's not the best, but it gives us anywhere between 60 to 85% protection. Not 100, it's better than 0. Case management goal: prevent death from dehydration. It's really what you're trying to do for this guy. Okay. Oral rehydration salts are the best thing we can do. Okay. We need to give him some actual IV fluids, which is very rare unless it's severe. And you give him some IV Ringer's lactate. And just remember, there are no labs. This is an emergency. You're in a natural disaster. There are no labs, so this is what you think this guy's got, and this is what you need to make sure you treat him. Don't try to say, oh, well, I'm going to do some labs. Don't have any labs. Right? You're in the middle of nowhere in a natural disaster. Right? Treat, move on. Okay, aggressive oral rehydration is a mainstay of treatment. We already talked about that. Majority of cases, 8 to 90%. One. If it does end up becoming severe, here it tells you use Ringer's lactate. Alright. So remember, when you poop a lot, you end up having those rice water stools, is what we call them, for the cholera. Right? So when that's happening, you're losing sodium, you're losing potassium, you're losing bicarb. You're losing a whole bunch of electrolytes that you have. Right? When you lose bicarb, that leads to metabolic acidosis, which is not good. So if you're able to replace it with oral rehydration salts, that'll help your patient quite a bit. Now, there it says antibiotics may prolong destruction of intestinal homeostasis. If it becomes severe, then we probably need to use antibiotics. Not what we really want to, but if it becomes severe, we need to use antibiotics. Generally for the mild cases, right there it tells you the majority of cases are 80 to 90%, we don't have self-limiting. Things that we have to keep an eye on, right? Clean water and sanitation, right? This will keep this stuff down, the GI stuff down. If it does become severe, then we can actually do IVs. Here it's telling you to use Ringer's lactate. Make sure medical personnel are actually doing the patient care stuff. Don't start grabbing people who don't know what their hygiene is. And then the cheapest, fastest, easiest way to take care of this is the oral rehydration salt, ORS. It is cheap and it's scalable in large outbreaks and epidemics. At this point, we're trying to figure out what you can do to help the masses. Right? And this is one of the easiest ways to help the masses. So this is basically what your oral rehydration salts are going to target. It's going to replace your glucose, sodium, potassium. Okay. And there it tells you it's recommended by the World Health Organization. And it's real simple stuff. You just take a liter of water, take one of those packets, dump it in your shake it up and make it drink. It tastes horrible, but it's going to help. Interrupt the fecal oral transmission. This is where you have your little teams try to figure out where the stuff is stemming from. Knowing that it's contaminated water, contaminated food, here fecal oral, you can keep some of that stuff clean via proper sanitation and waste disposal, hand washing, all this other stuff. Hopefully we can keep it conserved. That's literally what we're trying to do here. Acute respiratory issues. So remember, when you're in a smashed group, giant crowd, all together, sleeping right next to each other, breathing on top of each other, if one person gets a respiratory problem, do you think everybody else is going to get the respiratory problem? Yes. Okay. Has anybody seen a refugee camp before? Yes, no, maybe? Okay. It's kind of sort of what they look like. They're all on top of each other. There's no space there. Okay? So if one person gets sick due to a respiratory issue, the likelihood of spreading that respiratory issue becomes very easy to somebody else. Okay? So major cause of morbidity and mortality in emergency settings. Predominantly, who's most common? Children less than 5 years old. Okay. Up to 20% of all deaths are children less than 5 years old. The stuff itself speaks for us. So when we're out there, if we're trying to get immunizations, children less than 5 years of age should be one of those target populations we need to reach. Hopefully prevent them from getting influenza if we're going to use influenza vaccinations. So here you can see refugees and displaced persons are at risk. Concurrent disease, malnutrition, all the bad stuff that we know is occurring because they don't have it. Okay? Really predisposes them to a lot of this stuff. Right? They're overcrowded there. Right? They're on top of each other. Influenza complications. These are all things that can happen if you get influenza. Stuff we talked about. Complications of the flu. You get bacterial pneumonia. You get ear infection. You get sinus infections. A whole bunch of things. So we can prevent that. Keep some of this other stuff from happening. Right? Because if we don't prevent it, as you can see here, we end up with some complications that are going to be more common for them because they are more at risk. Their immune system is going to be lower, malnutrition is going to be lower, which means they're not going to be able to take care of themselves. So complications are going to actually start increasing if we don't nip it up front. Right? So influenza epidemics occur with marked seasonality. So depending upon what time of the year, wherever you're at, if it's influenza season there, that's going to be one of the common things you need to take care of. The other thing to remember, right, it's giving you your time periods there from the north and southern hemisphere. But the other thing to remember is it a developed country or an undeveloped country where they do or do not have a vaccine program in place? If they do, the likelihood of this occurring decreases drastically. If they do not, then that should be one of the things that you target when you go in and try to protect these people and help these people. Okay. Decision on influenza antigens include made in advance of the influenza season. What this is right here is talking about is more along the lines of how do I figure out next season what I need to give for influenza? Right? And that really depends on what's the most prevalent and or the most dangerous that we saw this season that we see a trend for next season. So the pharmaceutical companies will go ahead and develop that for the next season. Because we have trivalent, quadrivalent influenza vaccines, so we'll put more than one dose in. And from a layman's standing outside the box looking in, it almost looks like they're trying to take a lucky guess as to what's going to be the most popular next season, so that they can develop the next influenza vaccine. All right, you guys remember measles? Yes, no, maybe? What do we give to treat measles? Huh? Nothing. Antibiotics? Thyroid medication? Right, a lot of times measles is self-limiting, right? One of the things that does help them quite a bit is vitamin A. I suggest you remember that. Okay. and then it becomes extremely important when we talk about humanitarian missions because of malnutrition. If we do give people, kids particularly, vitamin A, usually decreases their ability to get measles. Okay? Keep that in mind. So one thing to point out for you, do you mind if I give you some tips for pediatrics next semester?
Never mind, free advice.
Free advice? Free advice, this is free advice. Okay? You guys remember what COVID spots are? No? Sorry. So let me help you out. COVID spots are those little white spots that you find inside the buccal mucosa of a kid that has the measles. Okay? 1 to 2 days before the rash starts, and as the rash starts, it goes away. Okay? I am telling you this because what I want you to understand is the COVID spots don't last very long, and it depends on where they're giving you the scenario for measles. Right? So she is a pediatrician, so she is going to be a lot more specific than I am. Okay? COVID spots is pathognomonic for measles. So if I see COVID spots, I say, yeah, that's measles, right? But you have to understand what stage of the measles you're at. Okay? So if you're in the prodrome stage, you will have those COVID spots, right, along with the conjunctivitis, the coryza, the high fever. Okay? But as soon as that rash pops up, that those COVID spots go away really fast. Okay? So read the questions that she gives you, because she is going to give you questions in reference to a time period of when things happen. All right? So if the time period is showing you that the person is already has a rash and it's starting to go away, then your decision should not be COVID spots tells me that that's what it is, because at that point you're beyond the COVID spot time period. Right? So just keep that in mind when you start doing pediatrics. Right? COVID spots are only there for a specific time period, very short, in the prodrome phase, 1 to 2 days, and they disappear pretty fast as soon as the rash starts around the hairline, back of the ears, across the face, down into the trunk. Just remember that, because that'll help you come up her stuff. Right. So here it tells you measles can be really dangerous. 1 out of 4 people who get measles will be hospitalized. 1 of every 1,000 people with measles will develop brain swelling, which is encephalitis, which is what we talked about. So this is a respiratory disease, so keep that in mind when you're in an overcrowded situation and you're coughing and sneezing all over the place. You're going to spread to somebody else, right? Now, you guys remember R naught? Remember that little number from the math that we did a couple slides ago? All right. So if you look at this, right? If you don't remember, R naught's that basic reproduction number of how many people are you going to get sick, right? So this one up here is influenza. Right? This is the source of the influenza. This person can infect 1, 2, 3, 4. So definitely 1, anywhere between 1 to 4 people. That's influenza. Smallpox is down here. Right? 1 person can infect anywhere between 5 to 7 people. But if you look at the R naught for measles, the 1 measles person can infect anywhere between 12 to 18 people. If you're in a crowded situation, there's a lot of people around you. Let's just say 1 person, I am your 0 person, okay? I'm standing here, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. So the first 2 rows plus half the 3rd row, I just infected with the measles. Okay? Now, last person in that 3rd row is gonna infect 18 more people, that's the rest of the room back there. And if these guys decide to step over here, they're gonna infect everybody else. And it takes three, I would say probably 4 of us to infect this entire room. How contagious the thing is. Right? Now, these guys are living on top of each other, so the ability for them to spread the measles becomes astronomical. So the sooner you can find this and figure it out, the sooner you can kind of sort of give them the immunizations for it, or isolate or quarantine. Okay? Because that is another thing that you need to do when you're doing natural disasters. If you have someone infectious, you have to quarantine them. Okay, remember the words, right? Quarantine means that that person's already sick. And they can spread it, so I got to put him someplace so it doesn't spread it until his communicability goes away. Right? And this is what we need to do during these disasters so that other people don't get sick. So measles still here, it tells you, remains a leading cause of mortality in children less than 5 years of age. So there is your target audience, right? Less than 5 years of age. And here it's just telling you it's a respiratory deal. You guys already know that. Right? Okay. There is worldwide distribution. You guys already know that. And malnourished children is another risk that we should try to target. Okay? Outbreaks are common in refugee settings, war, and other dislocated populations, which also include humanitarian missions that some of us may go on. This is what we talked about when we talked about measles. You guys remember me telling you, hey, there's some stuff that people are finding out that we really don't talk much about. So measles doesn't just affect the body, right? Measles also causes what we call immune amnesia, right? So it kills some of your memory cells, some of your memory B and T cells. Doesn't kill them all. Here it says, I think, 60% of children lose about 40% of their diversity, and that diversity is reflecting upon the different types of memory cells that they have. Right? And the memory cells that we have are built against the different disease processes that they were made from. Right? So we have some from varicella, we have some from HPV, we have some from adenovirus. So what happens with the measles is that it kills some of those memory cells. It doesn't necessarily kill them all. It'll take some months for them to come back after you get better from the measles, but remember that time period that you're missing some of those memory cells may make you more prone to those specific diseases that you don't have the memory cells for anymore, or as many anymore. So another thing to keep in mind. These are some of the complications of the measles. Nothing extremely bad, right? Death is 0.2%, so that's not bad. Right? So here are some uncomplicated measles cases, some cases non-severe, including the eye and the mouth, and then some severe cases. Right? I don't think I can make this any easier for you. Okay? What do you give to all of these guys?
Vitamin A.
Just remember, okay? Because that right there in itself, even if you don't do anything else for a measles person, malnourished person, okay, to protect them from the measles may help, even if you don't do anything else. Okay? And remember, here in the U.S., we don't do anything for that. Give them some vitamin A, and that's about it, other than supportive treatment here. Okay? Overseas, they can do some other stuff that we don't. Okay? Here it's telling you that the measles itself can unmask some malnutrition problems, vitamin A being one of those big ones, where you give them some vitamin A, and here at the bottom it tells you vitamin A alone administered to the high-risk target population significantly reduce the measles associated with morbidity and mortality. Okay? So even if we do anything, or nothing at all, best thing that we can do for them aside of supportive care is give them some vitamin A. All right. measles vaccination should be assigned the highest priority early in emergency situations. Okay? Immunization should begin as soon as the necessary personnel, vaccine, cold chain equipment, and other supplies are available. It should not be delayed until cases of measles have been reported. Right? We know, historical fact, we know that this stuff usually pops up when we have these types of situations. So instead of waiting for the situations to occur, we can be proactive and start giving out immunizations. Okay? As soon as we can. Because remember what that R naught number was, right? One person can affect anywhere between 12 and 18 people. And as that continues to happen, the numbers continue to increase drastically. So we can try to prevent it. Now, we talk bad stuff. People are going to die when you're there. Okay? You're going to be sometimes making that decision whether they're going to die or not because you don't have something to give them or can take care of them. It's reality. Okay? It's a fact. Now, the reason why I bring that up is because the World Health Organization has things like this slide. Okay? This keeps you from having to be that one person that says, well, we're going to give some stuff to you, but we're not going to give enough stuff to you. We'll give some stuff to you, but not to you, right? This gives you the target population that you need to address stuff and have the medications that you can. Okay? The target population for measles vaccination would be during the emergency phase. Okay? All children 6 months to 14 years with priority of 6 months to 5 years. Right? Priority up to 5 years, right? Because the most at risk is 5. So anyone below 5 is usually who we target, especially if we don't have enough. Now, if we don't have enough overall, we target undernourished or sick children 6 months to 12 years, all children 6 to 23 months, and children 24 to 59 months, which is 1 month shy of 5 years old. You don't have to necessarily concern yourself other than look at the data, look at the patient age, and if you think you see one that would benefit and you have the extra capacity to give it out, then by all means give it out. But if you are in a rationing situation and you're trying to do your best for the most, which is what we try to do when we're there, just go off of the guidelines that the World Health Organization has for specific disease processes. And the last one is the vector. Right, you guys remember that? So mosquitoes, kids, right? Come out, they'll bite you, and they'll go away. These guys are living in crowded situations, and we're talking arthropods causing problems like malaria, and we have to talk to them about, hey, you need to put a net around the area where you live so when you sleep, it doesn't bite you. Here's some DEET that's trying to protect you during the day so that these things don't bite you and then spread it to someone else. These are all the things that we try to make sure that we can capture. Here it's telling you when we have landslides or deforestation, when it's more of a water natural disaster, is usually when we see more arthropod problems. Because those guys become the natural vectors. Right? All right. The two main concerns there tells you malaria and dengue. And these mosquitoes. All right. Right. Prevention's key. That's really what we need to focus on here. Prevention. If we have no vaccines, right? We have some chemoprophylaxis for malaria, but not anything else. So vector control if at all possible, hand out some sleeping nets, right, and education best possible. Anybody have any questions? Yes, no, yes. All right. Thank you very much. I appreciate your time and your patience and your attention. If you guys have any questions, please let me know. You guys can text me, email me,